Thanks for joining us. I'm Matt Grossman, Director of the Institute for Public Policy and Social Research. We're pleased to put on today's very topical forum on vaccine distribution in Michigan. Thanks to Michigan State University and the W.K. Kellogg Foundation. Please plan to join us if you are a legislative staff member on February 5th, when we will have a staff training complete with the fiscal agencies, the bill writers, the clerks. Learn all about the legislative process on February 5th from 9 to 11 and 1 to 3. And then for everyone, we hope you'll join us for our remaining forums. The next one will be on February 24th on violent extremism. Now I'd like to turn it over to our moderator for today, Associate Director Arnold Weinfeld.
Thank you, Matt, and welcome everyone to this continuing series of public policy forums sponsored by Michigan State University's Institute for Public Policy and Social Research. Very pleased to have with us today three experts in their field and folks that have been very busy during the pandemic, and even more so now with vaccine distribution. And that is indeed the topic we have today before us, COVID vaccine distribution. With us today is Ruth Ann Sutterth, who's Senior Vice President for Public Affairs and Communications at the Michigan Health and Hospital Association. Dr. Deborah Furr-Holden, who is the C.S. Mott Endowed Professor of Public Health and the Associate Dean for Public Health Integration and Director of the Flint Center for Health Equity Solutions and Co-Director of the Healthy Flint Research Coordinating Center at Michigan State University. And also with us is Linda Vale, who is Health Officer for Ingham County. And I believe that Ruth Ann is going to start us off. Ruth Ann?
Thank you very much, Arnold. It's nice to be here today. Thank you all for having me, to MSU for hosting us today. It's an honor to be here with Linda and Dr. Furr-Holden. I know that they're going to have a lot of important information to share with you as well. But my role today is to bring you up to speed on what hospitals' role really has been in the vaccine rollout and what we see coming next, and how partnerships have played a really important role in where we've gotten so far today. So we can go ahead to the first slide. And my email address is there for everybody if you do have questions after today's discussion. So going first, I just wanted to level set and make sure everyone had a good sense of where we stand today on vaccines. As of yesterday's data that got posted, which means it was really as of the day before, we had gotten 1.47 million vaccines allocated to the state of Michigan. And the states got an ambitious goal that we believe we can reach of 50,000 or more shots per day. And so far, of those 1.47 million, more than 760,000 of those shots have been administered. And really the remaining, about half of that have been scheduled. And the providers that receive those vaccines are scheduling those as aggressively as possible. So there is not vaccine simply sitting in freezers without a plan. Every provider that's getting that vaccine is giving it out as quickly as possible. The Biden administration, which is in week 2 here, has a goal as well of 1.5 million shots in arms per day across the nation, and 100 million shots in their first 100 days. Again, these are goals I think with the right supply and the right partnerships, I think we can absolutely achieve. Michigan is currently still vaccinating its populations within 1A, 1B, and 65 and older. And what that means, 1A are healthcare workers, direct healthcare workers. 1B are certain essential workers. And we also have, as you can see in the chart at the bottom, we've pulled in part of 1C, which is anybody age 65 and older in Michigan. Those are the groups we're currently working through, understanding that there is always going to be overlap between these groups. And then lastly, I just wanted to mention that the state of Michigan now has more than 1,800 healthcare providers enrolled to be vaccinators. Obviously, right now, our limiting factor is supply. Most of those 1,800 are really not doing vaccines quite yet. Largely, that is a job currently being handled by health systems, hospitals, health departments, some of our qualified, federally qualified health centers and prisons. So we can go to the next slide. Thank you. In terms of where Michigan stands nationally, we are doing much, much better than we were early on. In the first couple of weeks, we were down ranked, I believe, 42nd or 43rd out of our 50 states when it came to how many vaccines were being administered per 100,000 people. And we are now up to 15th of our 50 states. If you include some of our territories, we're, I believe, 18th or 19th, but huge, huge improvement. And I think, again, that's thanks to the really, really hard work 24/7 of our hospitals and health departments to get these vaccines out into the community as quickly as possible. So we want to be even higher on that list. We know that Michigan could be a leader in this effort. So we'll continue to keep an eye on our national performance. Next slide. All right, with that background behind us, I wanted to talk a little bit about what the hospitals have been up to since mid-December when we started getting vaccine into Michigan. Thus far, about 50%, 57% of the vaccines administered across the state of Michigan have been administered by hospitals and health systems. And we do know that if we had a much larger supply of vaccine, we have health systems that could likely give tens of thousands of vaccines per week just on their own if that supply existed. And then at the bottom here, you can see where the vaccines have been administered over time since December 14th when we got those shots in hand. And you can see this continued upward trend in how many vaccines hospitals have been able to administer on a weekly basis, which is really good to see. Overall, the hospitals have been in a leadership role throughout the pandemic since we got patient number 1 last March all the way up till now, where we're luckily in a much better position in regard to hospitalizations and case numbers and positivity rates. So, our role has always been one of leadership in this pandemic, and that continues in the vaccine process. We know that most hospitals in their communities are a trusted place for healthcare for patients and for the community. And we're trying to take advantage of that and make sure that they continue to play that important role in their community by providing vaccinations. They also uniquely have a lot of data to identify people in the community that might be vulnerable and might need outreach to get their vaccine. And so they are working very hard to find those people in the community that need vaccination, working in partnership with the health departments to do that. And then we also are working through some variations in what hospitals' roles are in rural areas versus urban areas. Obviously, the capacity of different types of providers, the distance people have to travel, all vary across Michigan. And so we are trying to make sure that, especially in our rural areas, that hospitals continue to be able to provide those vaccines to their communities in partnership with other providers. One thing we don't have a super clear picture of right now and is still being worked on is what the role of hospitals will continue to be as we get into more mass vaccination operations. And I think as we learn more about the national role or FEMA's role in setting up mass vaccines in Michigan, that will be something that is kind of due to be determined. We have a lot of hospitals that want to play a critical role in this, and some that have less capacity. They still have to take care of patients. So more to come on what we see next from hospitals in the mass vaccination space. Next slide, please. So just to frame some of our ongoing challenges, at which I'm sure we'll hear some of this from our other speakers as well. We simply don't have enough vaccine in Michigan to get to everybody yet, and the demand is outpacing the supply. We have some small hospitals that have not gotten any vaccine supply since January 4th, and that is due to the the siphoning off of a certain supply of vaccine to the long-term care program, which is critical. We need everyone in those long-term care facilities, staff and residents, to be vaccinated. But that has left some smaller hospitals without vaccine since early this month. They still want to play a role, and hopefully we see that improve as we get more supply into Michigan. Another serious challenge that we're seeing in polling our members is that this hesitancy to get the vaccine does exist. And so we need to continue to provide education about the safety and efficacy of the vaccine to our healthcare workers, to our community members, to make sure that they understand and can feel confident making the choice to get their shot. We have continued, like I said, variation in providers' capacity and desired roles. And I think the state is continuing to align their efforts with the Biden administration, which will be really helpful in understanding, where hospitals, where health departments fit in, how can we work together to not be duplicating efforts, but be complementing each other's efforts. And that really gets to that role of our partnerships. Like I said, hospitals and health departments have played the lead role in vaccinating Michigan thus far. But every county and every locality looks a little bit different. Every hospital and every health department has different capacity. I know the health departments are working still on contact tracing and a whole host of other issues, and hospitals are taking care of patients and emergencies. So there's not a one-size-fits-all approach to how we vaccinate Michigan. We need to have local flexibility and strong partnerships at that local level. Next slide. And then lastly, this isn't too vaccine specific, but I just wanted to leave you all with some questions that I think we're going to keep talking about going forward and might be, discussions that we have with this group in the future. The pandemic has really left us with a lot of questions about what does healthcare infrastructure look like in the future so that we're better prepared for the next pandemic? Because unfortunately, it will happen again, hopefully not anytime soon. But I think that we've all learned a lot about what this pandemic means for different providers' roles, and we can better prepare next time for a vaccine rollout. I think we can prepare for what kind of investments we want to make in things like mental health and addiction services. We've seen a huge uptick in the need for those services in the pandemic and not enough capacity. What kinds of investments do we want to make in public health? How are we reaching out to vulnerable populations? We've had health equity, become a major focus throughout the pandemic. And those are all things that we need to plan for the next pandemic or the next crisis. We've luckily been able to work very closely with our partners in Washington, D.C. and in Lansing to adopt solutions and flexibility in regulations when needed to make sure providers can do their jobs while doing it safely and protecting their patients. But can we be more nimble next time? Can we have things in place so that all of these processes we've gone through at the national and the local level and at the state level can move more quickly when it happens again? We've seen a lot of changes to just care delivery, the adoption of virtual healthcare and people being comfortable having an appointment on Zoom has really skyrocketed. And how do we take advantage of that and again, improve equity and access in communities that may not be able to have traditionally accessed certain kinds of care? Can we use it better for our behavioral health services, especially in rural Michigan? And then lastly, are we going to Monday morning quarterback this whole pandemic, and how are we going to look at how Michigan plans for emergencies? Since the adoption of a lot of our plans at the state level, hospitals and health systems have become much larger and they cross regions. So that regional approach does work for some applications, but not for all. So what can we learn about that so that we're better prepared next time? So those are some questions I wanted to leave you all with to think about and things that we're considering at the MHA. And with that, I will turn it over back to Arnold. Thank you.
Thank you, Ruth Ann, and appreciate you taking time during this busy time to be with us today. A few things I should have noted to the attendees, as some of you have figured out, the chat function and raise hand functions have been disabled. You can ask questions through the Q&A box. And also one other note that this is being recorded, so it will be available through our website in the future. But a couple of questions right away for you, Ruth Ann. One from Shri Tanadar. Do you know which hospitals have not received any vaccines yet?
I wouldn't be able to share those names off the top of my head. But again, they were hospitals that had been receiving mostly the Moderna vaccine, and that's the vaccine that got shifted over to our long-term care partners. So there are a handful, I don't know exactly how many, but we've made the state aware of that. And again, it's just an issue of supply, but we're working on that.
And would you know what, from John Domas, what percentage of healthcare provider staff in phase 1A did or did not elect to receive the vaccine?
I can tell you from a survey of our membership, which about 80% of our hospitals responded to our survey, that the average acceptance rate for all healthcare workers who were offered the vaccine was between 60 and 65% on average. So that's good, we want to see that continue to grow. And what we did see, and we've heard even since the survey closed, is that as more individuals see the confidence level in their provider colleagues taking the vaccine and feeling confident in that they are more willing to take the vaccine themselves. So hopefully we continue to see those numbers go up.
And maybe one more for right now, and some of these we can get to later with our other speakers as well. But Mary Ablin asks, in terms of partnerships, have physician offices played any role to date?
So thus far, I know that some physician offices have pursued the enrollment process to become a vaccinating provider. Again, with such a limited supply, for example, the past couple of weeks, we've only gotten 60,000 new Pfizer vaccines for the entire state of Michigan. Those vaccines require very stringent and complex storage and cold chain and handling requirements that hospitals and health systems and health departments have sophisticated systems in place to manage those processes. And between the supply and those handling requirements, we're not quite yet to the point where we're able to provide vaccine to individual physician offices, but I know that they do desire to play a role.
Thank you very much, Ruth Ann. And I know that we are getting in several questions. We'll take a couple as we move along after each presentation, and then after each one is done, we'll go back to them. I know that Dr. Holden was double or triple booked, as busy as she is. And I'm wondering, Dr. Holden, have you joined us? Okay. Linda, since Dr. Holden has not joined us yet, are you ready to go? And you're muted, Linda. You're muted.
Turned on the camera and not the microphone.
Okay.
Sorry about that. Yeah, I am. I can. I don't have a PowerPoint. I'm just kind of here to talk about some of the things that are going on. Microphone. And I do want to go back to. Oops. Hang on just a minute. I got microphone issues. There we go. Mm-hmm. Sorry, I wasn't ready to go next.
I'm sorry.
So the document that the chart that you saw Deborah present is here. So there's more to it than that. But I want to point out that while we are vaccinating 1B, you'll notice this green bar of frontline 1B personnel is here. And then this other 1B personnel are out here. So we are not, in fact, actually vaccinating all of 1B right now. The other thing that happened is 65 to 74 were actually 1C. They got moved back in the timeline, but are still in 1C. So when we look at the 1B is 75 and over as a group A. And then we have group B, which are the groups that we are supposed to be working on now. So this group of people. So the reason some of these people are not getting vaccinated yet is because we have been told, I was in a meeting by the state yesterday, that we are not ready as a state to move on to this group C of 1B, just the group B. Then we jump down here and pick up the 65 to 74. So that in Ingham County, whoops, is a group of people, probably I would say 80, 90,000, with about 2,000 new doses of vaccine that we get every week. So it's a very large process. And we find out on Friday how much vaccine we get this week that will be arriving next week. So the logistical challenges of always needing to be guessing where you are with vaccine in terms of scheduling appointments and those sorts of things have been very challenging. As Deborah mentioned, excuse me, it's not Deborah, Ruth Ann, I'm sorry. As Ruth Ann mentioned, the supply has been fairly low, 60,000 Moderna doses a week across the state. That doesn't go very far when you distribute it to all counties. So I did see in the chat somebody asking about why we were at 60, we weren't doing 65 to 69 in Ingham County yet. We're not alone in that. Detroit started at 75 and above and then lowered to 70. And then I believe just lowered to 68. We are now lowering to 65 as well. But that doesn't mean the 65 to 69s will all of a sudden get an eligible appointment right now, because quite honestly, 2,000 new doses a week, 40,000 people in Ingham County alone, 65 and over. So we're moving through as fast as we can with very limited doses of vaccine, with very limited information about how much more vaccine to expect, with very limited information about what our allocation is going to be even for the next week until we find out that week. So, similar to Ruth Ann's chart that showed, we had a little bit more, vaccine on hand than we've administered. Some of that is because those are planned appointments. Right now, we've got about 15,000 doses of vaccine on hand, and we have given 12,200 of them. So part of that is that the vaccine that arrived this week, I certainly couldn't plan on for this week. So the vaccine that is in my inventory right now, which shows, is actually vaccine that I will use next week. And that literally is as far ahead as we can plan this. And as you might guess, getting our entire population vaccinated as quickly as possible, that's challenging from a logistics perspective, but we keep doing the best we can. The other thing is that and that's why I was hoping Dr. Holden would go before me, is that we always have to keep equity in mind. So what we're not used to within our system is really, having to think really about really a heavy emphasis on equity in terms of access to this particular, health system resource. So we have absolutely got to reach out to people who are most vulnerable, people who don't necessarily have access to a primary care doctor, some things like that really are very important in terms of equitable distribution of the vaccine. The rest of, the issue with vaccine is that we are also right now required to use 75% of our vaccine on our 65 and older and 25% on our 1B personnel. So I believe that it will as we get through the 65 and over with that higher prioritization, it's going to slow down that 1B essential personnel process until we get the 65 and over done and start bringing in more groups. So it is an ever complicated process and a giant mathematical puzzle to just make sure that we keep scheduling appointments every week. We administer every single dose of vaccine we receive within 5 to 6 days of when we receive it. And we keep scheduling vaccine appointments out into the future. We will be opening some more, I think, fairly soon, based on an assumption that we are going to continue to get vaccine. That has not been a problem so far. We have not had to cancel appointments, but we do, in a sense, keep stepping forward in faith. There's a Martin Luther King quote that says, just take a step in faith, or something like that. And then says, you don't have to see the whole staircase, just take the first step. So one by one, we've taken the first step, but unfortunately, as we continue to take steps, we still can't see the whole staircase. So, some transparency about really how much vaccine is available, what can we really expect, will allow us to plan. It's not that we weren't ready at the local level, just like our health systems, we can get out, we can get vaccine. We can get thousands of people done every week if we had the vaccine to do it. What we need is the supply. And if we have to tell our communities that the supply is not there at a level, until some point in the future, please just tell us so that we can communicate with communities better about what is truly available and what is not. So we've been trying to get through that fog of basically just really knowing what the straight answers are relative to vaccine and vaccine availability, and just keep really just doing the best job we can to get a vaccine in every arm, and to make sure that as we get these vaccines into arms, that we, one, stick to that guidance. We have to sometimes prioritize even within the groups, which is why Detroit started at 75 and over, then went down to 70 and over. I hear they're at 70 and over in Kalamazoo. We did start at 70 over. We're moving down to our 65 to 69s. Always encouraged them to register, but it was just a matter of, there just were not enough appointments. And, we've got some 80, 90, 100-year-old folks in the community. And there was, certainly a sense of priority of making sure we got, our most vulnerable in. What that does unfortunately do is we do have 65 to 69-year-old folks, and younger than that even, who have comorbidities that we really also need to address. So we've been strike teaming those efforts to do our best to get some of that moving. But we're still going to be sitting for a period of time before we move into a 16 to 64 age group, even where, you could potentially have a 60-year-old who has so many chronic underlying conditions that they might actually be more vulnerable than somebody in their mid 70s. But this is the way the phases have been laid out for us. This is the guidance that we follow. It was done in a way to try to create equity, to address a vulnerability index, as well as population of 1B personnel. So they have really been refining a formula for allocations around all of those things so that equity does lead, and that we prioritize when we have a very scarce resource. And sometimes even within the priority groups that are currently eligible, there is some sub-prioritization. So I think that there are some people that aren't aware that, all 1B essential personnel are not eligible right now. Just that smaller group that I showed you, and I'll put it up here again for you. Let's see, hold on. Which is really right here, this group of people, pre-kindergarten through high school, support staff, childcare, first responders, firefighters, police, conservation officers, inspectors, corrections staff in prisons, jails, juvenile justice facilities, workers in homeless shelters, congregate care institutions, and adult and child protective services. Again, state yesterday very clearly told us we are not in this group C of the 1B priority groups yet. And that is why I think we're, at a little bit of a synchronization problem with communication with our communities, because they can see these 1B groups in other places and don't necessarily see that prioritization guidance from the state of Michigan, nor do they necessarily hear we're only doing groups A and B right now. And then they can see that group C and know that we are still waiting to move on to the next group. So with a very, very scarce resource, and it even tells you when we get to that group C of 1B, that if vaccine is still scarce, we might have to sub-prioritize within that. We are still looking at vaccine being scarce. That's going to be thousands of people, and there might have to be some sub-prioritization if we don't get some influx of vaccine more rapidly. So that is some of the complications we're dealing with in terms of moving forward with vaccinating, moving forward in a plan that does tier things up and prioritize. And some of that is based on vulnerability, has to be done in an equitable way. And so that's kind of where we are with some of that process. So I'll stop there.
Yep.
But I just wanted to explain that, the health systems in this community, as well as the health systems across the state, your local health departments in this community, as well as across the state, are basically vaccinating people effectively and efficiently as fast as we can. We would all do more if we had more vaccine. We would all do more if we had vaccine. I was the emergency preparedness coordinator from Kalamazoo County when I first started in public health. And my job was to write these plans to get this vaccination effort done, mass vaccination and other emergency plans. And so I wrote the plan that says, how do we mass vaccinate this population? And at that point in time, this is 2002, there was apparently a credible threat that there would be a smallpox release in the United States. So what we were looking at is smallpox and that the severity of that. And so the marching orders from the federal government and the plans that we had to write and create with funding that allowed that program from the federal government said, you need a plan that will vaccinate your entire population in 3 days. So we have those plans. Now, did I ever think when I wrote that plan that we really truly would be able to do it in 3 days? 250, now I'm in a little bit bigger county, 1,000 people. I'm not sure, but it did involve multiple dispensing sites, availability of all the resources to do it, an all hands on deck effort. And would it have been done in 3 days? Maybe not. But could we do this in a matter of weeks or a month? I think we could. The limiting factor is vaccine, and the prioritization that you're seeing as a result of very limited vaccine is sheerly because of that, not because of a broken system in this state in the ability to administer vaccine. So there's been a national narrative that says we're sending it out and the states weren't ready, the states weren't prepared, et cetera, et cetera. And that's not true. We're ready, we're prepared, we're doing it. We could do more. And we would have this all done with an abundance of vaccine in a very short period of time, relatively speaking.
Thank you very much, Linda. Appreciate your perspective and open and honest approach. Also appreciate the fact that you addressed many of the questions that were in the chat. Before we get to Dr. Holden, there were two there that I think are still pertinent. Number one, there's been this issue of line jumpers. Are you familiar? Is this actually a problem, and what's being done to address that?
I think nationally we have heard about some issues about, vaccinating, and vaccinating some people who are maybe remote working or who are not frontline workers and things like that. And so that's something that's getting shored up and should be shored up. Have we done that in the Ingham County Health Department with vaccine we have allocated to us? Absolutely not. The only people that get vaccinated are those who are eligible by age or by employment. We require ID for both when people come to our clinics. So you either have to be by age eligible or you have to have an employer ID. We actually screen and work with employers so that they understand that, for example, I just talked to, I'll call out Kelly Dean because he's a great guy and we all know him, Dean Transportation. School bus drivers. School bus drivers are part of that education sector, all that. They're on a bus all day long with children. They need to be vaccinated. So when I had the conversation with Kelly Dean about vaccinating Dean Transportation, I said, just these people who have this, high level, intense all day contact with a large group of people and have an inability to mask and social distance. Well, what about my mechanics who interact with my drivers? Those are not the people right now. I need just these people. So those conversations with the employers happen to ensure that they send you the right people. Now, if the employer kind of breaks the rules a little bit and sends somebody to you, and then that somebody says, yes, I do that. Yeah, I'm a driver. Then you don't have a lot of control over that. So we do our best to make sure that that doesn't happen. And we, by all means, never intentionally allow that to happen in our system. In fact, I think you've heard some of the, I just want to add this one other part, there are extra doses at the end of the day. And so people just make phone calls. With Pfizer, it is true that we can come to the end of the day because the vaccine is only good for 7 hours once it's become room temperature. So we don't take it out of refrigeration at our mass clinic until, we know that we need 5 more doses. It's like, here's more cars coming in, we need 5 more doses. If we have any vaccine left over at the end of the day that has come to room temperature and needs to be delivered within 7 hours, we have a partnership with an urgent care that is operating 24/7. They take their doses, and they vaccinate their elder population that they have in their databases. So that's how we do that to make sure that we do not line jump nor vaccinate ineligible people. Has there been, I've heard stories that that has been happening, and that is something we just have to shore up.
Thank you again, Linda, for helping to get information in a very complicated and difficult situation. Dr. Holden, thank you for taking time to join us today. I know that you've been quite busy with all the duties that you hold and all the community work that you do. Please take us through your presentation.
Okay, great, and thank you. I'm sorry you called my name, and this is relevant for this conversation around COVID, because I tell people you got to do the work now to know where you stand, because when they call your number, you don't want to not be there, because you don't lose your place. You don't lose your right to be in line, but you might lose your spot in line. And as Linda shared with us, we got some bottleneck problems right now. So I hope this helps. I want to talk a little bit about overcoming COVID. And my good friend and colleague, Dr. Larry Reynolds, said, don't talk about the COVID vaccine, talk about COVID vaccines, because we know there's more than one. But I want to talk a little bit about reluctance and hesitancy in the African-American community. And one of the things I'd like to do first is say, bust a few myths that we have out. And the first being that vaccine hesitancy and rejection is high in African-American communities. That is a myth. That is actually not the case. In fact, African-American adult vaccination rates are only slightly lower for adults. And that's if you look at the major vaccines like hepatitis, influenza, pneumonia, and HPV. And when I say slightly lower, somewhere on the order of about 85, 90% of the relative proportion of African-Americans relative to the proportion of whites who get these vaccines. So vaccine hesitancy and rejection is not something that's very high in the African-American community. And in fact, when you look at childhood vaccination rates, they are nearly identical for all of the major childhood vaccinations like diphtheria and flu and hepatitis, measles, mumps, rubella, polio, and chickenpox. And all of those statistics are available from the CDC, and they're in a nice summary format on the Office of Minority Health website. And I have shared this PowerPoint with you, and the full link to the URL is in the notes if anybody wants to have this. Another myth, that vaccine hesitancy in African Americans, and specifically COVID vaccine hesitancy, stems from old stuff like the Tuskegee experiment. And that is also not true. There are lots of modern day inequities in healthcare and other systems that are also driving people's, that should say, mistrust and sense of fair play. And I just use this as an example. Early on in the pandemic, we saw that hospitals were overwhelmed and they had to come up with these systems for prioritizing care and who could be admitted and who didn't. And I just tip my hat to Massachusetts because they were at least honest, transparent, and forthcoming in saying the way that they had created this scoring system to prioritize and ultimately ration ventilators and beds, et cetera, actually those guidelines they figured out were actually prioritizing white patients over patients of color. So it's not just the history, it's also the modern day problems that we're seeing, and well-meaning people forced to operate in tough times, not bringing cultural sensitivity and that lens of equity to the work continues to fuel the problem of mistrust. It's not just the past, it's also the present. Last myth, that COVID vaccines resistance in the African-American community is due to misinformation and mistrust. And I want to dispel that myth. I've probably now had a dozen or so live talks that we've hosted with partners in Flint and Genesee County. I've also done a few talks with folks and partners in the DC metro area and in Baltimore because I was at Hopkins before I came to Michigan State. I'm also, in addition to being on the state task force and our local Flint and Genesee task force, I'm actually on the New York task force with Senator Nina Turner, and we're seeing very similar things there. This is not all misinformation and mistrust. There are some people who are well informed and they have simply said no, or they've said no for now, or they've said, I'll wait and see. And the one that I hear the most is you go first. You go, let me see what happens with you. Let me have some time and then we'll see. So I just wanted to give some context and background and make sure that we dispel a few myths around some of the hesitancy that we're seeing. specifically in the African American community. So then the real question, and as a public health person, we're looking at solutions. What are the solutions and what helps us to create a path forward? And I call them the 3 T's, and I'm gonna break them down for you. And I think it's transparency, it's trust, and it's time. So what does transparency look like? The first thing is, we've got this great model, and this is this Swiss cheese model that you've probably heard lots of folks talk about, many different graphics for it. This is the one that appeared in the New York Times. So you can just literally Google Swiss cheese model, New York Times, and this great graphic will come up. And the thinking is that multiple layers improve success. And admittedly, no one layer by itself is imperfect. So if you see on the left there, you've got the virus. And then you've got these slices of Swiss cheese. And if you know how Swiss cheese is made, you know, it gets these air pockets inside and they don't go all the way through. So as you start to layer multiple pieces of imperfect layers of protection, what you ultimately end up with is you end up building this wall of protection. And the vaccine is one very important, albeit imperfect, important layer of protection, but it doesn't let us off the hook for continuing to monitor and stand for these other layers. And oftentimes, and you'll see it sort of broken out by personal responsibility and shared responsibility. And in that, under that umbrella of shared responsibility is also governmental responsibility. So you see one of the layers says government messaging and financial support. So if we want people to stay at home if they're sick, if we want people to wear masks, if we want people to shelter in place, the reality of it is people need resources and supports to be able to do that. And so the vaccine, I think we need to locate it in a much larger and transparent model that says this is an additional layer that's going to improve our success in bringing this pandemic under control. But we shouldn't overemphasize or take our focus off of some of these other important layers. So then the second T, trust. How do we build trust? It's about relationship, right? The trust gets, you know, sometimes you can grant people trust, but when trust is undermined or when trust is violated, you've got to rebuild it. And relationships are built on trust, and trust takes time. It's a quote from one of my very best colleagues, Mr. Isaiah Oliver, who's the CEO of the Community Foundation of Greater Flint. And he's also the founding chair of our Flint Task Force on COVID inequity. And so in this world of trust, there's two things I want to highlight. It's the trusted messages that we want to get, and that's use of good science and the good practices of health communication. We know a lot around how to communicate things to people, both in ways that they can understand, but also in ways that prompt behavior and prompt action. And I don't think this is one of those cases where we want to sort of shoot from the hip. We have a lot of science and understanding around how to communicate to people, and we should be bringing that to bear. We also need to rely on the best, most accurate science data and information at the time. Again, in the world of being transparent and being trustworthy, it's fair. And I believe that people are big people. And it's fair to say to people, this is what we know and what we understand at the time. But that should be based on good data and science and not based on fiction or myth or, you know, people's own thoughts or opinions about it. If you do that, you oftentimes will undermine the messenger. And then we need validity and reliability checks. They're necessary. We are in our 46th week of our Flint Community COVID webinar. And one of the things that we learned very on in that early on in that process is we would have people who would come on and say, you can call this number to get that, or you can go to this website to get that. And then even before the webinar would end, people would say, I called that number, they gave me this number, I called that number, they gave me that number, and then I called that number and they gave me the original number that I called. So it's important that as we put these messages out, that we've got people who are actually trying and testing it out, because we underline our credibility when we send people on a wild goose chase. And I love how Linda was talking about the way that they're framing now, you know, people getting in line and this notion of people skipping the line. It's really important that people understand and that we give them the good information and test those systems, because there are people who their number has come up, but there's not vaccine for them right now. So it's important that they know if you're calling this number, what you're going to get right now is your name on the list, not an appointment to be vaccinated. So we got to do those validity and reliability checks for all of the systems and the resources that we roll out to people. Then there's the power of the trusted messengers. So it's not just the message, it's also the messengers. And sometimes the people who have the mic need to pass the mic. And there's a whole movement now around, and they're saying, take the mic, and take the mic, that works too. But I believe we should also be passing the mic. Who are the trusted messengers in community? How do we elevate the voice of community? How do we elevate the role of faith leaders? How do we elevate the role and the voice of grassroots community organizations? People who already have trust and relationship with the very populations that we're trying to see. So now the number has come up for many of our senior citizens. How are we engaging some of the organizations and the groups that are already working with this population, that know how they like to receive their messages and what their needs are? So this is really a time in the world of trusted messengers to elevate the voice of the community. And then we also need to strengthen the voice of local trusted sources. People ask all the time, where's the best place for me to go to get information? And 9 times out of 10, I'm pointing people back to the local health department. And so it also, I think, is an opportunity for trusted messengers to also do the reach out and be real partners with our local health departments. That is where a lot of the action is happening. And if it's not the place where action is happening, it's at least the place where we can get valid, trusted, credible information. And then we also need to be exploring the role of influencers. There are many in our community across all ages who really have the juice with people. And it's unfortunate that some people, and we've seen this nationally, use that voice in ways that spread myths or spread misinformation. But again, if we start to drill back down to the local level, most people at the local level are deeply steeped and invested in their communities. So I think that's an untapped resource that we need to continue to unpack and expand. Who are the influencers in our local community, and how do we pass the mic to them, shore them up, and also elevate their voice? And because Linda mentioned it, I put in a quick slide as she was talking just to touch on a few things related to equity needs and some critical conversations that I think we need to be having around equity. And you already touched on it, so I won't go too far, but we need equity in vaccine access for high risk and for vulnerable populations. And equity and access isn't just about, their numbers come up. It's also about, do they have what they need to actually be able to access the vaccine? In many places, and we've seen it in cities all across the country, people only had one way to sign up, and that was online. Well, of course, we know we have a big digital divide. So if people don't have other ways in, even if their number has come up, we've built inequity and inaccessibility into the system. And so we just need to bring that lens of equity and thoughtfulness to make sure that people have what they need when their number does come up to be able to access that opportunity. We also need equity in distribution, and that is not just a local thing. I am a part of a movement, and we are pushing for global equity. We have certain parts of the world that have received very few doses of vaccine, and those parts of the world tend to be poorer countries, and they tend to be Blacker and browner countries. And so equity in the distribution, both globally and nationally, is something that we're going to have to continue to attend to. And then we also need equity in other COVID-related resources. If you go back again to that multiple layers improved success, just getting people the vaccine without having payroll protection and supports for small businesses, without people having access to unemployment and a guaranteed income so that they can actually honor a shelter-in-place order if they don't have the kind of employment that they can do from home, is critical. And so we need equity in these other COVID-related resources that we're rolling out right now so that everybody has what they need to stay healthy and weather this season. I'm going to stop right there. I'll answer some questions. All my contact information is there. I've shared the PowerPoint. You're free to share it with others. There's my email. It's holdenc3@msu.edu. I'm also on social media, and my social media handle is Dr. Deb for Holden across all channels. And not that anyone uses it, but I always put my cell phone number up. If anybody ever has a quick question or comment or concern, you can always text me. Thank you so much.
Dr. Holden, thank you very much. And I want to thank our panelists, not just for taking time for their work. They've also been answering many of the questions that have been posted, and we've had over 20 questions during this webinar posted. Some of you have answered them through your presentations. Others are taking time to answer them directly. One of them that's still hanging out there that I'll pose to any of you, do we really think we'll be able to vaccinate our way out of this? What about vaccination education, including other priorities and safe practices? But are we going to be able to vaccinate our way out of this? I mean, it's now mutating, and I think that there's some issues there as well. So anybody want to take that one on?
I can try unless somebody else would rather. I mean, I'm also a former molecular biologist. So when we start talking about strains and mutating, it's an RNA virus. That's to be expected. Okay. Flu is an RNA virus. I won't get into the full DNA and RNA virus molecular biology reasons, but DNA viruses don't mutate as much because they got like a fancy error proofing function when they replicate, and RNA viruses don't, which is why we have a new flu vaccine every year. It's yet to be seen whether the COVID vaccine is going to be an every year vaccine or an every 3-year vaccines, or maybe an every 10-year vaccine like the tetanus vaccine. We won't know that for a while. But between vaccinations, like with flu, as well as, you know, the message we give every flu season, which is, you know, cover your cough, stay home when you're sick, wash your hands, get your flu vaccine. Those messages will be, we will expect it to become endemic in the United States, just like flu is endemic, but we've got better protection with this vaccine when we're talking 95%. So what that means is, endemic means it just like H1N1 is still in the world and in the community. It's the predominant flu strain right now. After it was a pandemic, it became endemic. We have 4 common coronaviruses that cause the common cold. They're endemic. They're here. This one will become endemic, but it shouldn't be as severe. And the vast majority of people we vaccinated against it as we continue to get through these vaccine hesitancy issues. And as we keep moving along that way, then the vaccine is probably one of our biggest tools to get us out of this, but it's not the only thing. We still will have every season, when it becomes respiratory virus season, the need to say those messages about covering your cough, staying home when you're sick, washing your hands, and maybe now, you know, wearing a mask if you know, those sorts of things. So those things are all going to have to continue to be incorporated into it. And not to talk for too long, I just wanted to mention to Deborah, your pass the mic issue. And I want to ask you, because I always like to touch bases with people, because, you know, I hate to say something that's offensive. I refer to it as, we have to, some of us like me, have to find our people in the community that can trust me, right? And then can basically broker that trust. I refer to them as trust brokers in a way. And I don't know whether I coined that term or not. I want to make sure it's not offensive, but sort of like you said, pass the mic. What I need to do often is basically have conversations with certain people and then let them help me move that trust forward.
Sure. Listen, I love it, Linda, and I love the notion, and we talk about this a lot in our work in Flint, of being a broker and a bridge. So when I say pass the mic, it can go multiple ways.
Right.
It goes miles for communities to hear directly from the health officer.
Right.
You know, and what I had to explain to people, and it's a tough situation to be in. I unfortunately can't do it all one-on-one. If I did, I would just be up 24 hours a day answering people's questions and trying to get them navigated. So when somebody reaches out to me from a church, I say, get your church together on a webinar, or let's have a conversation. We'll record it, and then you can roll it out to people and we can have it transcribed, right? Because it makes more sense for me to be able to do it for a group rather than an individual. Similarly, it's fair for you to say to some of your partners that you're building, hey, can you pass me the mic and help me to, that was one of my points. We've got to elevate also the voice of these local trusted health departments, these local health departments.
But then we
So,
get
yeah.
to, a handful of people and we allow them to be our trust, like I said, our trust brokers for us. It's like,
Yes,
I get the mic
absolutely.
for a little while, but then I need to pass it on to the people that the rest of that community now will trust.
Great
Yeah,
point.
and it gives your voice much more reach and impact as well. If you can almost deputize other trusted, credible messengers to bring the word forward. So imagine if you were having a briefing once a week with 30 or 40 of those people. They would then reach thousands in the community vis-a-vis you empowering their speaking.
So
Great idea.
one last question I'd like to get to. I know everyone's time is precious, but one last question I'd like to get to, and maybe Dr. Holden, given your work in Flint, you might be able to address this. What's being done to reach out to other underrepresented populations in the state, such as the Hispanic community or tribal councils or undocumented persons?
So I'm less, I can tell you from the state task force, I can't speak to what's happening with the information dissemination around vaccination specifically. What I can speak to is we saw tremendous racial disparities in COVID very early in this outbreak. The big striking one we saw was with African Americans, and we took that on. And how we took that on is we had a multi-sector table full of people. We laid out what we saw as the problems, and then we implemented solutions that matched the problems. What we did not do as well was do the same thing with the Hispanic and Latinx population. And guess what? It's not all of the same barriers that they face. So the basic model, if you really want to deal with equity, is you identify the disparities that you see downstream, but then you got to turn around and look further up. What are the systems, the structures, the social and political determinants of people's health and well-being that are giving rise to those disparities that we see downstream? And a lot of those barriers for many of our Hispanic and Latinx community are a little bit different from some of the barriers that we face with African Americans. We got lots of reports of people saying, I appreciate the barrier-free community testing. I don't feel comfortable presenting myself in these places because I'm concerned I have people in my household who are here and don't have all of their proper documentation. Right. And we've seen cases of ICE agents and things like that using opportunities and people coming to access resources and putting themselves in harm's way. So I think the work is underway, and there is a mass media campaign that's being rolled out right now by the state, and they've hired multiple communications firms who are steeped in these cultural contexts and getting the word to people how and where and in a way that makes a difference for them.
Linda, what about at the even more local level here in Ingham County? What efforts have been undertaken to reach those kinds of populations?
So we've always had a health department that has lots of community organizing and grassroots efforts and partnerships. And so that is happening. That was happening in preparation for the vaccine, as well as, we also have to, we get these allocations of vaccine, we put out a link, people schedule, right? Even that has some privilege embedded into it in terms of being savvy enough to do that, having received the information to do that, all of those sorts of things. So the rest of what we do is we do take some strike teams into the community and reach out specifically to some of our leaders or places where we know we can reach our Black and Brown communities. So I think that was Linda Delgado Kip that was on there. We do have a clinic coming up at Cristo Rey coming up real soon. So those are some of the examples of ways that, we reach out. We do, quietly, we've really been very quiet about our efforts to vaccinate because a big public, here we are, splash, just draws people to a facility where there aren't appointments, draws people, media to a facility that causes problems. And quite honestly, we were concerned about security issues as the rollout began with the vaccine itself. So, so quietly in the background, Linda, rest assured, we are making those efforts, and we'll be with Cristo Rey, and I believe that other communities are looking at how do they reach out to a lot of their special populations, the indigenous population, as well as our Latinx population, as well as our African-American Black population. So
I know the case of trust and trust brokering and the like as well, for sure. Ruth Ann, anything to add to that, or what else might be of interest to the attendees?
I would just, echo those comments that, those are the types of things happening around the state. Depending on the community, it's going to be different voices and trusted partners doing that outreach. I would also just mention that earlier this week, the governor did appoint the Protect Michigan Coalition, or commission, I should say. And that commission, of which I'm lucky enough to be a member, is going to be working on this exact type of issue. How can we ensure that we are getting the right information to the right populations in a way that they can access it, to be sure that equity is there across the state. And so there is a very diverse group of stakeholders that sits on that commission, and we're getting started on Friday. Yeah. So yeah, we're starting Friday, and there will be more to come. And so our work will be all year.
Thank you. So one more question, perhaps. Julie Mack looks like she's been crunching some numbers regarding per capita vaccine distribution, and claims that more people are getting vaccinated at a higher rate in the UP than some areas of the Lower Peninsula, the same Metro Detroit. And yet I've also been reading about complications in rural areas as well with getting vaccinated. Can somebody talk to that comment by Julie at all? Is that an accurate way of describing the situation?
I can speak to that a little bit. Julie, thanks for the question. I haven't crunched those exact numbers myself, but I can say that early on, again, at the beginning stages of this, when vaccine was initially distributed, it was largely Pfizer. And so there were Pfizer shipments sent to some very small hospitals in the UP that had the storage to do that. And so they were able to quickly, vaccinate a large population. I'm from Gladstone, a town of 5,000 people. You can vaccinate 20% of the city in one day with Pfizer. So I think early on there was a lot of vaccine there, and that's evened out over time as we've learned what the allocations are going to be across Michigan. But I don't have the actual numbers in front of me, so happy to turn it over to Linda if she has a comment to add.
I don't have the exact numbers either, and Julie and I speak frequently. Part of it, and just to piggyback on what Ruth Ann said, the rest of that is that Pfizer only comes in 975s. So if I get a first allocation, and that's all there is across the state, I get 975. If there's a health department in the UP that gets their first allocation early on, they also get 975. 975 goes way further in the UP than it does here. So that was the only vaccine available early on, and it only came in allotments of 975. So that very much is the reason for that. Moderna vaccine comes in allocations of 100. So you can get 100, 200, 300, 400. And now that we've got Moderna in the mix and the state is distributing it out, they do have a population-based as well as vulnerability index, as well as I believe they're throwing in some factors that help with 1B essential personnel calculation in order to allocate vaccine. Because, like I made the argument that in Ingham County, because 1, largest public university in the state, 2, all the state departments are here, plus some federal agencies are here, that Ingham County, as a population of 290,000, could very well likely have more 1B essential personnel and 1C essential personnel than, say, Ottawa County, which has about the same population. Every single state department is in Ingham County. So there's got to be some consideration for that as well. And I think they're working out all of the different metrics to make sure vulnerability index, population, and all of those things get taken into account with allocations.
That's a great point, Linda. Again, thank you for denoting how complicated this situation is. All right, I'm going to do one final one, I promise. But it's about production, and all of you have touched on it a little bit. And there was a question about whether a vaccine manufacturer right here in Lansing, Emergent Biosolution, which over the years has done vaccine production work, should the Defense Production Act, which was talked about early on in the pandemic being instituted for PPP, PPE equipment. Should that now be instituted for vaccine production? Is it possible to do that for vaccine production? Any thoughts?
Sure. You know, President Biden has said he does want to invoke the Defense Production Act. And I think we want to see that happen because, like Linda said, this could be a vaccine that we need every year, you know, going forward into the future. But changing your factory to produce vaccines is a lot more complicated than changing your factory to produce widgets or masks or something else. The type of cleaning that you would have to do on the front end and then changing those production lines, sharing the information and the formulas, it's just a lot more complicated process than it is to switch over a manufacturer to producing some other type of you know, object or device. So we want to see that as because the sooner it can get started, the sooner later this year that there might be some assistance. But in terms of having new factories start to produce this vaccine, it's not going to be a silver bullet or an immediate solution.
Thank you. Thank you for that comment. Greatly appreciated. And again, I want to thank you, Ruth Ann, Linda, and Dr. Holden, all of you for taking time this afternoon for presenting information and your perspective on what will be a developing and continuing situation in this country and around the world for some time to come. Thank you to our participants and our attendees and the questions that you posed. Matt, do you have any final thoughts before we close out?
No, thanks to everyone for coming.
Okay, and remember, our next forum will be on February the 24th, so look for notice of that. Thank you all again, and have a great day.